This conference will now be recorded.
Yeah, sir. Good afternoon, everyone. Am I audible to you?
Yes, sir.
Yes, sir.
Okay, today we will discuss about pituitary tumor syndromes. So previously we already dealt with the pituitary. So pituitary morphologically is divided into anterior lobe and posterior lobe. Anterior lobe, other name is adenohypophysis, whereas posterior lobe is called neurohypophysis. Already we discussed about it, how the from the hypothalamus to pituitary how the connections are, and from pituitary how the to end organs how the axis will be. Okay, this is the again a brief revision of what we have read in the previous class. Okay, for the anterior pituitary, the hormone secreted from the hypothalamus will be transported through the capillaries or the portal vessels. Okay, whereas for the posterior pituitary, directly the neurons will be extending into the till the posterior pituitary. Okay, that is the difference we have read. And this also this slide similar to thing we have already discussed in the previous class. This is the hypothalamic factors and this is the pituitary. In the pituitary gland there are 5 types of cells: somatotropes, thyrotropes, lactotropes, gonadotropes and corticotropes. Okay, these are the cells secreting different type of hormones from the pituitary gland. For these cells to secrete these hormones, there will be a hypothalamic factors which are released from the hypothalamus, which will in turn regulate the release of pituitary hormones. For example, growth hormone releasing hormone will be acting positive effect on having positive effect to secrete a growth hormone from somatotrope cells, whereas somatostatin, in the name itself it is a statin means inhibitory, so somatostatin will be inhibitory to the growth hormone and TSH also, mainly growth hormone, but on TSH also some effect will be there. Okay, and this also we have discussed, dopamine will have a negative effect on the lactotropes, so prolactin release will be decreased. Okay, thyrotropin releasing hormone will have a positive effect on lactotropes and thyrotropes, so it will release prolactin and TSH. Okay, so this point is important. TRH will increase the secretion of both TSH and, usually we already know TRH will increase the secretion of TSH, but also prolactin, it will increase the secretion of prolactin. Okay, and gonadotropin releasing hormone will increase the production of FSH and LH. CRH will increase production of ACTH. Okay, this is the hypothalamo pituitary axis. Okay. And one more point is the histologically the cells in the pituitary gland can be divided into acidophils and basophils. Acidophils include somatotrophs and lactotrophs. Okay, so if there is a tumor involving the acidophils, then the patient will present with both increased production of growth hormone and prolactin. Okay, so you will have combined features of hyperprolactinemia and acromegaly. Okay, they may give you there is a tumor involving the acidophilic cells of the anterior pituitary gland. What hormones will be increased? So it will be both growth hormone and prolactin. All other 3 cells are basophils. Okay, you just have to remember acidophils are somatotrophs and lactotrophs. Okay, these are the posterior pituitary hormones we already know: vasopressin and oxytocin. So if you want to divide the symptoms of pituitary disorders into 2 groups, we can call it due to hyperpituitarism related effects. If there is a tumor involving one of these 5 groups of cells, then there will be increased production of the pituitary hormones. Or if there is only mass effect, already we have discussed previously, like Sheehan syndrome and all, there will be hypopituitarism. Okay, So this all already we have discussed this also. Local mass effects will be like any pituitary hemorrhage, or if there is any craniopharyngioma or any tumor compressing the pituitary gland, then there can be hypopituitarism. Okay, and there will be local mass effect related symptoms like increased ICT, and there will be close proximity of the optic nerves and optic chiasma. So bitemporal hemianopia. This all we have discussed already. Okay. You can see this, the relations of the pituitary gland. If there is a tumor in the pituitary, what is this? What is this? On either side of the pituitary?
Hmm.
Someone
Cis.
answer. What is all this blue color part? On either side of pituitary, what is the blue color whole thing? What is it? This is cavernous sinus. In the cavernous sinus, what all cranial nerves will be there in the lateral wall? Ophthalmology, you might have read, no? What are the relations? Lateral wall of the cavernous sinus, what all will be there? Cranial nerves. Here it is there now clearly. Oculomotor nerve will be there, trochlear will be there, and trigeminal V1 and V2 also will be there. Okay. So whenever there is a tumor in the pituitary, there will be mass effect on one of these cranial nerves. So there will be cranial nerve palsy. So patient can present with a cranial nerve palsy also. Okay. Diplopia. Patient can present with diplopia due to involvement of the cranial nerves 3, 4, and 6. Okay. So there can be mass effects due to pituitary, like hypogonadism, hypothyroidism. Last class we have discussed hypopituitary. Or if there is a mass effect on optic chiasma, bitemporal hemianopia will be there, more on the superior aspect. Okay. Or if there is optic nerve compression, directly blindness, patient can present with blindness. Okay, there is a compression of hypothalamus. Hypothalamus will be regulating all our body, like body temperature, appetite, and all will be regulated by the hypothalamus. So whenever there is a compression of the hypothalamus, then there will be temperature dysregulation or a change in the appetite and thirst, and there will be obesity, diabetes insipidus. This all we have discussed. Okay, cavernous sinus. If there is already just now we saw the picture. If there is a compression of the cavernous sinus, then there will be ophthalmoplegia due to involvement of the 3, 4, 6 cranial nerves. Okay, there can be diplopia. Facial numbness is due to involvement of the which cranial nerve?
Trigeminal.
Yeah,
V2.
fifth nerve. Anything V1, V2, V3, everything is a face only. We have to divide, no? V1
Yes,
is
sir.
above that angle of the. Okay. Frontal, if the frontal lobe is compressed, then there will be anosmia or personality disorders. Okay. Raised ICT symptoms already we know. Headache will be there. Any hydrocephalus can be there. All this can be. Okay. These are the symptoms due to local mass effects on various structures in the in and around the pituitary gland. Okay. So the pituitary tumor syndrome, already same slide only. The neurological symptoms will be headache, diplopia due to cranial nerve 3, 4, and 6 cranial nerve compression. There can be temporal seizures or any meningeal signs can be there. Ophthalmological signs will be diplopia, decreased visual acuity, and reduction of the visual field. There will be hemianopia. No? Okay, if you do MRI, there will be enlarged sella turcica. If there is a pituitary adenoma, we can see the mass. Okay. So in normal MRI also, if they take MRI for us, there will be a bright spot in the pituitary. Pituitary will appear as white spot. Why? Because there will be high phospholipid content in the posterior pituitary gland. So in the posterior pituitary gland, there will be high phospholipid content, which will be visualized as white bright spot in the MRI. So that is called pituitary bright spot. That is a normal finding. It's not abnormal. Okay. So this is for identification of the pituitary. Whenever you see MRI, if there is a white spot, that is pituitary. If the white spot is enlarged, you can see here, this is the enlarged. So the white spot is enlarged. This is called pituitary adenoma. Okay, so you can classify pituitary adenomas into micro and macro adenomas based on the size. So less than 1 centimeter will be microadenoma and more than 1 centimeter will be macroadenomas. Okay. So what is the use of this classification? Microadenomas, more the symptoms will be due to production of the hormones. Like if it is a prolactin secreting adenoma, then there will be hyperprolactinemia. Whereas in macroadenomas, the symptoms will be due to mass effects. Okay. So based on clinical features, we can think what type of adenoma it can be, and it will be useful in the management. So macroadenomas are mostly dealt with surgery, whereas microadenomas, medical therapy can be given. Okay. So overall, what are the screening tests for the functional pituitary adenomas? Last time we discussed about hypopituitarism. Today is increased secretion of the pituitary hormones. If there is an adenoma involving the pituitary, one of the pituitary cells, then there will be different manifestations. So if there is acromegaly, it is due to increased production of growth hormone. So what test you will do? Growth hormone ultimately will, what it will do, it will act on the end organs and increase the insulin like growth factor will come. So this is the final hormone through which the growth hormone acts on the peripheral organs. Okay. So growth hormone will act on the liver, and liver will produce insulin like growth factors, which will further act on the peripheral organs, target organs. So already previous class I told, I think, oral glucose tolerance test. So growth hormone, you all remember, huh? What will happen whenever we give insulin? Previously we discussed about hypopituitarism, no? When you give insulin, what will happen? What will happen if you give insulin? Sugar levels will,
Hypoglycemia will come, sir.
so hypoglycemia will be there. Then what our body will do?
Then
What hormones
glucagon
will be
will be
secreted?
released. Glucagon.
Glucagon and what else?
Thyroid hormones, cortisol,
And growth hormone also.
growth hormone.
Growth hormone also will be released. These are all against insulin. Insulin will be one side and all these hormones will be other side. Insulin will cause hypoglycemia. All these hormones will cause hyperglycemia. Okay. So similar thing in hypopituitarism, what we did, we gave insulin and we saw that due to hypoglycemia, what we will expect the growth hormone levels to rise. In hypopituitarism, if there is no sufficient rise in growth hormone, then we will think of hypopituitarism. Here it is quite opposite. It is a hyperpituitarism like syndrome. So we are having increased growth hormone. So what we will do, opposite to insulin, what we'll give, we will give glucose. Then there will be hyperglycemia. So growth hormone, what it should happen to growth hormone when you give glucose? What do you expect growth hormone to be? Decrease or increase? Decrease. So this is the opposite of the test. So you are giving glucose and you will check the growth hormone levels at 0, 30 and 60 minutes. So normally if they do for us, we will have growth hormone suppression that will be less than 1 microgram. So if there is a, if the growth hormone is not less than 1 and it is more, if it is 4 and all, then we will think of growth hormone secreting pituitary adenoma. Okay, everyone understood? Similarly, prolactinoma. Prolactinoma will cause excessive secretion of serum prolactin. So we should explore the drugs causing prolactinoma. This all we'll discuss again. And the third thing will be Cushing's disease. What is the difference between Cushing's syndrome and Cushing's disease? What is Cushing's syndrome?
It is associated
Both
with
are same
adrenal syndrome. Adrenals also.
So syndrome is a blanket term, not only adrenal. Syndrome is whenever there is increased cortisol levels in the body, then that is called Cushing's syndrome. In Cushing's syndrome only, if the Cushing's syndrome is due to pituitary cause, then we call it Cushing's disease. So Cushing's syndrome includes both Cushing's disease and other causes also. Okay. Cushing's disease is nothing but Cushing's syndrome due to pituitary adenoma. Okay. So whenever there is Cushing's disease, what do we do? Screening test is 24-hour urinary free cortisol test. Okay. And one more test is dexamethasone suppression test. Similar to this glucose test only. We'll give dexamethasone and we'll check the cortisol levels. Okay. We'll discuss it in detail again. So normal subjects, what will happen to cortisol? Cortisol levels will reduce. But if there is an adrenal adenoma, then there will be increased cortisol levels. So how do we manage this pituitary tumors? Main treatment modality is surgery. Surgery is through transsphenoidal approach, through endonasal. Okay, through the nose, we'll go to the sphenoid and they will resect the pituitary tumor. Okay, or if it is not feasible to do transsphenoidal resection, the other option will be radiation. That is called stereotactic radiotherapy. That is, the radiation will focus on the only pituitary gland. Okay, what is stereotactic? That is, previously when we used to give radiation, what will happen? There are many side effects because the radiation will not be only due to the tumor cells, it will be to the surrounding organs also. That's why there are many side effects. But nowadays it is stereotactic radiotherapy. That is, the radiation will be focused on the tumor cells only. The surrounding structures will not be exposed to the radiation. That is called stereotactic radiotherapy. One of the example will be gamma knife radiotherapy. So these pituitary tumors, they account for 10 to 25% of the brain tumors, most commonly between 20 to 50 years of age. Children will have, very rarely they will have pituitary adenomas. In children, most common tumor will be craniopharyngioma. Okay. Most common pituitary adenomas are prolactinomas. Okay. Both men and women, it is prolactinoma only. Okay. Most common cause of both hyper and hyposecretion of pituitary hormones is pituitary adenoma. So even if it is hypopituitarism also is due to pituitary adenoma, that is due to mass effect. If it is hypersecretion of the pituitary hormones is also due to adenoma, due to hypersecretion of the hormone. Okay, both hypo and hyperpituitarism, most common cause is pituitary adenoma. Okay, it includes 15% of the intracranial neoplasms. So already we have told 5 types of cells will be there in the pituitary. So the tumor can be from lactotropes, somatotrope, corticotrope, thyrotrope, gonadotrope. Any of these cells can be arising. So the hormone secretion do not correlate with the size of the tumor. So we cannot tell a small tumor, 2 mm tumor can also produce large amount of hormone, whereas a 2 centimeter tumor may not produce any hormone. It can be non-functional also. Okay, non-secreting pituitary adenomas also may be there. So the hormone secretion do not correlate with the size of the pituitary adenoma. Okay. So already we have discussed the classification of pituitary tumors. Micro will be less than 1 centimeters. Macro will be more than 1 centimeter. Okay. And the other classifications can be due to benign. They can classify it benign and malignant. Okay. You can see the pituitary adenoma, a big pituitary adenoma. Okay. Same thing. Okay. These are some of the syndromes associated with pituitary tumors. Already you might have read MEN1. What is MEN1? It is multiple endocrine neoplasia 1. It is due to gene MEN1. Okay. Menin gene is involved, which is chromosome 11. Okay. What are the clinical features? What is the triad in MEN1? Can someone answer? MEN1, what are the 3 Characteristic features.
Medullary carcinoma, hyperparathyroidism.
No. Medullary is not there. That is men 2. Men 1 will be parathyroidism, hyperparathyroidism, pancreatic tumors,
Pheochromocytoma.
and no. Pheochroma is also men 2 only. This is P pit pan. P is for parathyroidism. Pit is pituitary. Pan is pancreatic. So it is P pit pan. Hyperparathyroidism, pancreatic, and pituitary adenoma. These three are the features of men 1. What you have told medullary thyroid carcinoma and all will be men 2. 2 is again divided into 2A and 2B. No, again we'll discuss when we discuss about men syndromes. We'll talk in detail. Okay, you just remember in pituitary adenomas are seen in men 1. Okay, also in men 4 also. This is very rare. You just remember men 1. Okay, Carnes complex. Carnes complex is pituitary adenomas, atrial myxomas, and lentigens. There will be hyperpigmentation. That is called lentigens. Okay. Carnes complex, main you have to remember pituitary adenomas, atrial myxomas. In cardiology, they might have taught you Carnes complex. Okay. And there are lentigens. These three are the features of Carne complex. And the other thing is familial pituitary adenomas. This is not so important. Okay. You just remember men 1 and Carnes complex. These are associated with pituitary tumors. Okay. So first we will discuss about hyperprolactinemia. These are the most frequently occurring adenomas in men 1. In men 1 already we have discussed there will be pituitary adenomas. What is the most common pituitary adenoma in men 1? If they ask, it is prolactinoma. Okay. So it is more common in reproductive age group women. So in men and postmenopausal women, it often appear to be clinically non-functional. So 50% of the prolactinomas are grossly or radiographically invasive at initial surgery. They will be invading the surrounding structures. Okay. So in both men and women, most common pituitary hypersecretion syndrome is due to hyperprolactinemia. If the prolactin level is more than 200 microgram per liter, then it is most commonly due to prolactinoma. So do you know any other causes of increased prolactin levels in the body other than hyperprolactinemia, other than adenomas? Are there any other causes where prolactin will be increased in the body? Can you tell some conditions?
Hyperthyroidism.
Hyperthyroid, rarely. Common things you tell. Pregnancy. In pregnancy and lactation, there will be increased prolactin secretion. What is the function of prolactin?
Production of milk.
So during lactation and pregnancy, prolactin levels will be increased. Okay. So it can be physiological increase like pregnancy, lactation. During sleep also prolactin levels will be high, and during stress. Okay. Or any hypothalamic pituitary stalk damage. Previously we discussed, no? Whenever there is a pituitary stalk is cut, what will happen? All the hormones production will be decreased except prolactin, because hypothalamus is having negative impact on the prolactin through dopamine. If that negative impact is not there due to some pituitary stalk damage, what will happen? Prolactin level will rise. Do you remember this? Previously we discussed now
Yes, sir.
during last class. Okay.
Yes, sir.
So other systemic causes also are there like CKD, hypothyroidism, cirrhosis, and epilepsy. Okay. All these are why hypothyroidism. We have discussed now TRH, thyrotropin releasing hormone, will cause increased production of prolactin also. So whenever there is hypothyroidism, what will happen? T3 T4 levels will be low, so that will cause a feedback to the, that will give a feedback to hypothalamus. What will hypothalamus try to do whenever the T3 T4 is low?
Increase TRH production.
TRH production will be raised. So whenever there is TRH production raised, TSH will be increased, and along with that there will be raised prolactin levels. Okay, this is a very important point, because whenever you incidentally find some patient prolactin level is increased, what you should do? First, you should rule out hypothyroidism. So you do TSH, T3 and T4, because this prolactin disorders are not very common compared to thyroid disorders. So whenever you see prolactin levels high, then you should check for hypothyroidism. Okay, in clinics it will be very important. Okay, so these are the systemic causes of raised prolactin levels, like CKD, hypothyroidism, cirrhosis, and epilepsy. Epilepsy also. You might have read in neurology differences between true seizures and pseudo seizures. In true seizures, prolactin levels will be elevated, whereas in pseudo seizures it will be normal. Okay, and some drugs like cimetidine, Rantac, metoclopramide, verapamil, fluoxetine, all
Sir,
these
how
drugs
is
also.
CKD, sir?
Which one? How
In
is
CKD, how it will be raised, sir?
mechanism?
Yes, sir.
Mechanisms are not clear actually. In CKD, that mechanism is not clear. They found that in these conditions, prolactin levels will be raised. There is no particular mechanism given. Okay.
Okay.
So how the patients will come to you? So there will be, due to increased prolactin levels, what will happen? Common thing you know is, without reading only, you will be knowing galactoria will be there. There will be production of milk. Okay, and there will be amenorrhea. Due to increased prolactin levels, amenorrhea will be there, and there is infertility. So a reproductive age group female will come to you with a problem of infertility. Then you should check the prolactin levels, and you should ask for other two symptoms like amenorrhea and galactoria. If some reproductive age group female is coming to you for infertility, then you should ask whether she is having any galactoria and amenorrhea. Okay, and then you should go for the levels of prolactin. Okay, if the patient is before menarche, what will happen? Then they present as primary amenorrhea. So the patient will come to you like menses is not attained. Okay, puberty will not be attained. That is if it is before menarche, but it is most common in reproductive age group women only. Okay, so 80% of the patient women will have galactoria. So this is the most common presenting symptom in hyperprolactinemia. So the other symptoms like decreased libido, weight gain, and mild hirsutism also can be there. So in male patients also, if there is hyperprolactinemia, they can have infertility due to decreased libido. Okay. Why it is happening? It is due to gonadotropin suppression, which leads to reduced testosterone and impotence and oligospermia. Okay. So you have to remember galactoria, 80% of the patients, and the patient comes with infertility and amenorrhea. Okay. Other things you will remember. So what laboratory investigation you will order? You will order the basal and fasting levels of the prolactin. So normal prolactin level will be less than 20 micrograms. So if there is any hypersecretion, it will be more. Already we have discussed, if it is more than 200, you should think of pituitary adenomas directly. If it is between 50 to 200, less than 200, then you should think of other causes like drug causes or any physiological conditions and all. It will be less than 200 only. If it is more than 200, you think of adenomas. Okay. The male to female ratio, female to male ratio will be, for microprolactinomas, it is 20:1. Microprolactinoma means, what is the size of the tumor? Less than
1 centimeter.
1 centimeter. So microprolactinomas are more common in women, whereas macroadenomas are common in both, 1:1 only. Okay. So how do you treat these patients? what are our goals to treat? What is she coming with? Mainly her complaint is infertility. So you should restore the fertility. You should try to restore the fertility. And the tumor, there can be macroadenomas, no? There will be mass effect. So you should try to reduce the size of the tumor. And the other thing is we should reduce the level of the prolactin, because the increased levels of prolactin will cause all sort of symptoms like loss of libido, hirsutism, weight gain and all. So you should control the levels of prolactin and you should resolve the galactorrhea. So these four will be our goals for the treatment of hyperprolactinemia. Okay. So what do you do? What I have told you, dopamine, what it will do? What is the impact of dopamine on prolactins?
Inhibition of
What
prolactin.
will inhibition? So what do you want to give, dopamine agonist or antagonist? You will give agonist. So there are two drugs, cabergoline and bromocriptine. Cabergoline is D2 receptor agonist, which is long acting. Okay. If you give cabergoline today, for 14 days, the effect will be there. So the tumor size also will be reduced. If you are thinking, wait, the tumor is very large, for surgery it is very difficult. So prior to the surgery, you will give cabergoline. What will happen? The tumor will shrink in the size. Then you can go for surgery. Okay. So it is a long acting drug. Whereas bromocriptine will be, it is an ergot alkaloid derivative and it is a short acting drug. Both are dopamine agonists only. Okay. So bromocriptine, when do we use? If you are considering the patient for pregnancy, so you want her to be pregnant, then you prefer short acting drug, because during pregnancy these drugs are contraindicated. You should not give these drugs. So you go for short acting drug like bromocriptine when you are planning for pregnancy. Okay. So what are the side effects for these drugs? There will be constipation, dry mouth, postural hypotension. And with the use of cabergoline, one characteristic side effect is there, that is it can cause valve regurgitation like MR and TR. Okay. So this is the overall management protocol for prolactinemia. What should we do?